Hi. I'm actually going to talk about mental health. That's okay. Let's try that again. I'm Kylee. I'm an oncology social worker, so I'm going to talk about mental health and cancer today. So thanks for having me. And just to kind of get us started, this is going to be kind of more of like a journey and a story, how things intersect both personally and professionally in the world of cancer and oncology. And I'm going to weave kind of some professional experience with some personal examples of how our lives just kind of crisscross and zigzag all over. So green forward, let me see if I can advance this correctly. So thanks for having me. And let me back up. I looked at what the mission of this conference was, and it's to provide knowledge to elevate and support quality cancer care. So the intervention or the skills might be kind of basic for you. Everybody comes at a different starting point. And so it's going to be basic overview of mental health, as well as intermediate concepts to provide comprehensive cancer care. And I love that, because that's treating the cancer patient as the whole person. And what I really like to say is that the doctors and the nurses do such a phenomenal job taking care of the patient's body, but there's also their mind and their heart and their spirit that also is part of the treatment plan and their healing journey. And so that's really great to be inclusive and multidisciplinary and have comprehensive cancer care for patients. So hopefully the goal would be to increase knowledge and enhance professional development. And so those are the goals of the conference. My goals and objectives, I just wanted to outline real quick. Since mental health and cancer is such a broad topic, like where do you start? You know, because it could cover a lot of, we could get into a lot of different diagnoses and treatment interventions. But what I want to start with is just what my goals of this talk would be today, which is to provide a safe environment for you personally and professionally. And to kind of destigmatize what mental health is. Even just being a social worker, there's a connotation that patients will say, well, I'm not crazy. I don't need to meet with a social worker. I don't want to meet with a psychologist because I'm not crazy. Or she's going to take my kids away. So I really want to kind of drill down onto what mental health can be in the context of something really specific like cancer or any type of chronic illness. Second goal would be to be helpful to you, whether that's something you're already hearing and it's just a good refresher, or it's something maybe that you can walk out of here with some tools in your tool belt. Again, both personally and professionally, what we can talk about today can be implemented in your personal lives as well, and to empower you. So the awesome nursing staff that you are. So just before we get started, I want to give you guys an opportunity when you saw kind of maybe the topics on the agenda and the conference today, what would be some kind of 3 things that you would want to walk out of here with? If you want to take a minute and just maybe jot that down, feel free, if you feel safe and comfortable, to raise your hand and just, let me know if there would be something specific you want to get out of this today. I asked a bunch of my buddies at work, I see a few in here today, and one of the nurses said, well, is this for the staff's mental health or the patient's mental health? And I was like, both, exactly. And that's why I said both personally and professionally. So just take a minute if you feel like sharing and, sharing what a good kind of goal is. And then that way we can kind of detour if we need to, some time talking about what would be helpful. So just real quick, is anybody feeling brave? Okay. Oh, thanks.
So I think how to empower people.
Okay.
When they're just feeling so down or what have you.
Yep.
Just how can we empower them?
Yes. Okay. And I'm going to drill down on like how to empower patients and families, because there's times where you feel really helpless. Yeah? You ever felt helpless? Especially, somebody who progressed or some recurrent disease, and there's no right thing to say. So yes, we will. That is definitely something we will hit. Anybody else? Yes.
I think too, empowering ourselves as nurses, so
Yeah.
that we can reach out and have those uncomfortable conversations and getting out of our own comfort zone.
Do you want to say that again real quick? Okay, thank you.
Okay, can y'all hear me? I said also as nurses, knowing how to empower ourselves and have those conversations with our patients, it can be very hard to get out of our comfort zone and reach out and dig for that information.
Great, thank you. Okay, anybody else? How about just one more, just in the interest of time? And if not, that's okay. We can keep cruising. We got a lot to cover in a short amount of time. The last thing I want you to do is do a data point for me real quick, if you feel safe to do that. You've had a long day, and I just want you to say on a scale of 1 to 10, pain scale, 1 being you're on the beach, 10, you just looked into a light like I just did, and you're like, oh no, I can't see. What is your stress scale right now? So don't share it with anybody. You don't need to raise your hand. Scale of 1 to 3. Just baseline 1, I'm doing good. 10, oh my gosh, I can't concentrate because I'm thinking about work and my kid's orthodontist appointment this morning. So just real quick, data point number 1, and then we'll move on. Okay, so like I said, this is going to be kind of a journey that we're going through, how mental health and cancer intersect. Starting with kind of, how did I get to this place? How did I get to be standing in front of you today, which I consider an incredible honor, so thank you for having me. And the reason why that's an incredible honor is that this kind of speaks about how we start an assessment of a patient, or any of us really, is our core schemas and our core values of who we are, what we've learned based on where we've grown up, and what we believe about the world, how we make sense of the world. So I'm gonna just use my personal story as an example of my core values and my core schemas, just being vulnerable, and to give it some context. So what I grew up here in Colorado, but starting before that, I'll actually start with my grandmother, who was a nurse and graduated in 1940. I have her class ring from the Shreveport Charity Hospital in Louisiana. She was married to my grandfather, who was a major in the United States Air Force as well as the Army, and fought in World War. My mom was a special education teacher for 30 years, so that's where I have a heart for the underserved and, learning how to help patients in need. And my dad was a history teacher, but then he went and fixed machines and radiation. And so he worked for Varian. Any radiation nurses in here? Yay! Okay. So I literally grew up with a sticky note in my lunchbox. I even brought it, that says, I love my clinic. So radiation is literally what I grew up with. And so to say that it was just part of my schema and how I understood the world, I've never been afraid of, oncology, and that's something that I've just grown up with. My sister's a radiation therapist, and one of the things that I learned in a family of scientists, much like this conference, they are left brain thinkers, and I'm a right brain thinker. I'm the creative, kind of very artistic metaphor thinker. And that's what social work is and mental health can be, is it's very soft science. And maybe, I think to your point, the question that you had, how do you empower yourself? How do you dig in and make it clinical? And how do you really get teeth around something that isn't black and white? Cancer is very gray, and it's really messy because patients come with their stories. They come with who they are and what they believe about cancer and what they believe about their health. That's really where you start. And so that's why I want to talk today with my schema and kind of how I come to this field. I also know, based on my family, my dad was Mr. Fitness, and he ran 6 miles every day. I am not a runner. I'm a heck of a sprinter. I am just not a distance runner. And I'm too sensitive. And we're going to talk about that here in a minute, how that can translate into what we think about ourselves later. So, great childhood, growing up in Colorado. It's beautiful. We have snow and sunshine in the same day. And as I headed off to college, my professional and personal life took a major crash course. And at the time I was going off to college, my dad got diagnosed at 45 years old. Mr. Bran Muffin, runs every day, never smoked a day in his life. And it was like the world shattered. And that's what a diagnosis does to patients and families. It's not just the patient, it's their kids, it's their wives, it's their neighbors. It's everybody who ever has any type of, care for that person, and that's that helpless feeling. We want to kind of race in and take them a hot tater tot casserole and show them how much they're loved. And so while I was going off to college, my dad goes to MD Anderson to go get treated on the same machines that he's been talking and breathing and living for the past 20-something years. And so that was where this professional goal came into my mind, to be a medical social worker, because he said, Kylee, I went to New York. A medical social worker found me a church, a running route, and an apartment that was close to the hospital. That's what you need to do. And so I spent my career getting to this place. So like I said, it's an incredible honor to be up here and sharing my story with you today, which makes me want to take a little bit of a pause and talk about resources for kids and families, because it's really, really important. Something that was traumatic to me as a child, or not as a child, but a toddler adult in my young 20s, leads me to a profession in oncology where I can help talk to patients about how to talk to their kids about a diagnosis, how to take something that could be ultimately traumatic and turn that into something that we have growth from, right? And so just some local resources I kind of threw in here for you I think this has a little Zoom feature. Okay, there we go. There is something called Climb. Is anybody familiar with Climb or Kids Alive? It is something where when you're talking with your patients and they mention that they're worried about their kids and they're worried about how I'm going to tell my kids in this way. These two resources, Climb and Kids Alive, are designed to help give kids tools and language, to make them feel safe, how to understand that you're feeling scared, how to not internalize your anxiety. If you're angry that mom can't take you to a basketball game or dad can't go to your track meet because he's on chemo, how do they get those tools to learn to deal with that? Aside from how am I going to beat my illness and cure my cancer, I would say the number one concern that patients have is, how is this affecting my family and my loved ones? Seem kind of helpful to maybe look at some tools for how to talk to families and kiddos. Judy's House is another phenomenal organization. It is a grief and bereavement program for parents, or for kids that have lost a parent to cancer. And it's really play-based. It's an amazing program. The Denver Hospice also has something called Footsteps. So you can get kids in a palliative care program that are talking early conversations about what to expect as far as death and dying. Because I can tell you, from the littlest, 5-year-old to a 25-year-old, some of that big weight of what they carry is my parent going to die from this? So it's kind of stating what the elephant in the room is and giving them tools with how to deal with it. So mental health is so broad, and that's why it's really specific to make sure that it's accessible not just to patients, but the whole family system. Heartlight Center is a community resource that we also can partner with that offer support groups and different things like that. So there's lots of resources out there. It's not your job to remember all of it, but just know there's a lot of different resources within our communities, including schools and what's offered in their local community. Any questions before I move on? I want to try to make it interactive so you don't fall asleep on me, but okay. So off at CSU, I specialized in a bachelor's of social work, and the first thing you start with an assessment is what's called Maslow's hierarchy of needs. Anybody familiar with this? Yep, perfect, love it. Because what do we do to patients in treatment? We knock them down to that physiological first step. They go to radiation for 4 weeks, 7 weeks, and they come home. They go to the grocery store and they're crashed for 2 hours because their gas tank is empty. And so I can't talk to people and do, existential therapy and conversations about who they want to be and post-traumatic growth when they can't pay rent and put food on the table, right? So Social Work 101 is starting where the patient is at, and nurses know that better than anything, right? So I know I'm kind of telling you what you know, but then there's also what is I found really helpful is looking at where the person is in their life stage. Think about it this way. If you are treating a 28-year-old with a 3-year-old at home for breast cancer versus a 80-year-old with CLL, they're going to have very different concerns and different needs based on their life cycle. A lot of times that integrity versus despair, people have to retire. They have to step away from careers or relationships or roles that they've had for many years to now treat cancer as their full-time job. And so this is a really helpful kind of framework to think about where is this person in their life stage, and also help them identify where they are in their stage. So a lot of mental health is really just reflecting. This is what I see, this is where you're at. Does that seem right? It's, it's kind of like that trial and error, like, hey, does this fit? Does this seem like you've, this hits a target? And patients will tell you when you're on track or you're off topic, and they're gonna tell you what you need to know about them if you're willing to kind of listen. The last thing with like just kind of an overview of looking at somebody and then their psychosocial concerns is them as an individual, them and their kind of family systems, their communities, their jobs, and then like the micro and then the macro, right? What's happening in their world? Cancer certainly disrupts that. And it was interesting as I put this slide together, what does this look like? Little tiny virus called COVID. It just has a way to screw up everything, doesn't it? But it's interesting, if you look at that, what does that impact on a macro level? Our culture, our history, our economics, our social conditions. It has completely rechanged our world. The world we knew it before February of 2020 is night and day from what it is, 2 years later. So this is a very helpful framework to understand that our world can be shattered by tragedy and traumas. And mental health is all about how to acknowledge that and honor that, but how to give them tools to rebuild. Okay, so now let's get into the landscape of cancer. All right, we ready to head down that road? Anybody want to throw out a question or need me to stop for any reason? Okay, I'll just keep cruising. So the way I think about a cancer diagnosis and that trauma is the conveyor belt in an airport. They literally get a diagnosis and it's like, this was where I was headed, but now I've got to go get a CT scan or a biopsy, and I am just hanging on for the ride. My caregiver's going to walk left and I'm just going to stand right. You know that feeling when you're just kind of standing there and you're getting pulled through? And what happens, we map it out for them really, really well. But then what also happens? Oh, well, my sister's cousin's neighbor had this type of cancer, so you should try this, and you need to go to Mayo. So they're getting bombarded with all this information. Where do I go? What should I listen to? Is this right to make this decision? And they're doing it at such an accelerated rate. And so a lot of times patients are really just kind of in that trauma mode of just hanging on and wondering if I'm going to die, right? And why I love that image of the atomic bomb is that is just what went off when you told them they have cancer. And what happens in the best intentioned support systems, and what do people want to say to fix and make it feel better? Just be positive. Just have a good outlook. Meanwhile, you're staring at like a mushroom cloud and you're like, yeah, but I might die. So it's really, really hard. And what therapy does and what mental health is really all about is just naming it. Hey, of course you're worried about a diagnosis. A scan coming up. Oh, don't worry about it. I dropped off my kindergartner today and I said, oh, don't be sad. And what am I teaching her? Don't feel what you're feeling. And therapy is exactly the opposite. It's saying it's okay to be scared. It's okay to be facing your mortality. Kind of the trajectory of where patients are with going through treatment, that traumatic response, boop. I'm sorry, what? You said cancer, and then I heard nothing else. Yeah? And they're drinking from a fire hose. And then they go into fight mode. Some of them go into flight mode. I don't want to call and schedule my 6-month follow-up MRI. Ugh, I just kind of want to avoid it. Or freeze. I have no idea what to do. How many times do you hear patients say that? Just that paralysis by analysis. I have no idea what to do. And these happen at very different pivotal points in their care. New diagnosis, absolutely. Change in treatment. They feel like they've failed their chemo And I had a patient say, my chemo failed me. Adjusting to survivorship, getting off that conveyor belt, now what? I saw you for 7 weeks for radiation and my therapists were awesome, but now what? I don't see my doctor for another three months. The fight mode is continuing to fight. Oh, you're in that's a very kind of interesting concept, and it's maybe a different talk for another time, but, getting into fight mode, people are running a marathon they didn't train for. And the cone keeps moving. You're supposed to finish this cycle. Oh, sorry, your labs came back, and now you got to bump it out by a week, right? And so people are used to kind of having things be predictable. And it's just kind of understanding that at all these different points, any of these different responses can be happening kind of internally and externally. So the cone moving constantly. I had a marathon runner that kind of gave me that analogy. My cone keeps moving. They keep moving my cone. But that's also a strategy for how to navigate, breaking things down and not having patients be so overwhelmed is how do you eat an elephant? You got to do it one bite at a time. So her cycles, she had 12 cycles of Taxol, and she said that her halfway point was cycle 4, which was really interesting because everybody was like, no, it's 6, right? Because we want to make sure you're getting 12. She's like, yeah, I know, but I moved the cone because cycle 4 is that first curve, that first step that I start doing that. That's how she runs a marathon. You don't start off by doing 26.2. Again, I'm not a runner, so give me some grace for the runners in the room. Heck of a sprinter. But 26.2, man, that sounds exhausting. So breaking that down to 13.1, and then half of that is what? And half of that is what? So 12 cycles, that can also be a strategy for people, another tool to empower people with, hey, how do you keep grinding? How do you keep going through something when you just don't want to run and you didn't train for this marathon and you didn't sign up to race it, right? You guys still with me? Okay. So how do we kind of tease out the body versus the mind? And where I think about this is are these side effects or are these just worries about side effects? Do you already have anticipatory nausea and anxiety because you're getting chemo? It's a natural response that people have. But a lot of times that's where I partner with nurses and I work really, really closely with, the multidisciplinary team. Is this, what's their baseline? Are you fatigued because you had, chemo rads, or are you just not wanting to get out of bed? What's the difference? Is it your gas tank? Is it your physical body? Or is it more not a clinical term, but you've probably all felt it, meh, I should, but meh. So it's kind of teasing that out and separating that out and looking at some different factors. Are they just not getting joy and doing the things that they should be doing? Are they isolating? Yeah, I could go see my grandkids, but I'm going to be such a downer, so I'll just stay at home, right? That's depression. That's not treatment-induced side effects. So we really have to kind of work together and make sure we're not missing any of those red flags. Pre-existing conditions, people, cancer is the emperor of all maladies. It knows no bounds. So people that already have these pre-existing disorders will get cancer, and then what happens is they are magnified with their cancer experience, similar to their relationships. A couple that didn't have a great, strong marriage before is going to come into cancer with that experience, but just magnified. Somebody who doesn't want to ask for help, it's going to be even harder for them to ask for help when they need it the most. So we really have to kind of break these down and see what did they come to the table with. Also compounded complex grief. That's one thing after another after another. It's, the country song that my car stopped working and then my dog died and then my wife left, right? And it is compounded. But life is still moving at 1,000,000 miles an hour and you still have to go get a scan. So just keep grinding and keep going. So what mental health is meant to do is to break it apart and to separate it out and to try to kind of compartmentalize and contain as much as we can. What is the most heavy thing that you're weighing? And this is where I like to really put metrics to things with patients and name it. On a scale of 1 to 10, how worried are you about your son's something or other, his grades? An 8. And this can be a really effective strategy with, communicating with, their supporters. You know what, meals, we're good, we're two. But can you take my dog out while I'm getting chemo? Sorry, I know I'm digressing, but anxiety is those things that just keep you up and worried. A lot of times this catches up with patients at nighttime because they are busy during the day, they're working and they're running around and they're doing this, and then guess what happens? Their body is just like, yep, we're done. But the mind is like a light switch that's just running. And all those what ifs that they've been kind of running from during the day. And then, like I said, it's just magnified by that treatment experience and that diagnosis. Personality disorders, these are fun. This is that reflective, like, this is what I see. Is this what you see? And they're like, nope, not me. Everybody else. Not my fault. These are personalities that are hardwired. We do not change people's personalities. We can try to give them tools. We can try to give them awareness, but they have to be willing to do the work. You can lead that horse to water, but you cannot drown them in it. They have to be the ones that want to say, yep, I need help with X, Y, and Z. And we manage this together as a team. The best mental health intervention for personality disorders is consistency and cohesion, not staff splitting, right? You have those patients or family members that keep calling to try to get that one staff member that's going to tell them yes when everybody else said no. So this is why it's really, really important for you to work together, providers, schedulers, soup to nuts, everybody kind of on the same page, because that's how you can kind of hold boundaries and barriers. I'm just going to kind of skip over this because I want to get to some of the end of the slides and leave a little bit of time for questions. But crisis management and abuse strategies, we're all mandated reporters. You guys know that. I just have to put it in there. But it's really scary, right? Like, what happens when we're talking about child abuse or our patients are vulnerable and they're at risk? So how do we make sure that those vulnerable populations are protected? Know your policies, talk to your team. Every place I've worked at, which has been a lot, I've been doing social work for 20 years, and 15 of that has been in oncology. Every single place I've worked, it's different. The policy is different, but it's always usually the same thing. You're de-escalating patients, you're trying to get them safe, you're trying to like organize resources, but the problem is this usually happens on Friday at 4:30 on a holiday weekend. So the best thing I think is like just talking with patients about their safety strategies. Hey, if you're gonna be, driving over to your sister's house, or you're feeling, thoughts of suicide, or, you're really in a dark place, not just handing them a list of phone numbers. Let's program that into your phone. Let's get that, so you can just, who are you gonna call? And if it's 3 in the morning and that person is awake, who's your second person? And if worst case scenario, you're just calling 911, right? So we're teaching patients how to do these tools. Good interventions aren't me in the counseling session with a patient for an hour once a month. It's the patient out there in their lives when they have a trigger and they learn how to kind of help themselves through these like really difficult situations. Suicide, one of the highest, there's certain populations within cancer that have higher rates of suicide. That's head and neck, pancreatic, lung. Men have a higher rate. Patients with prior substance abuse, especially if they're getting, pain management issues. That's something we always want to kind of assess, is a prior history. And the biggest indicator of if a patient is likely to be high risk or to complete suicide is hopelessness, that they have zero hope left. And so one of the interventions is, I think, I'm excited for the keynote speaker, but it's resiliency. What is that person's resiliency? Do you have a plan? The assessment is, do you have a plan? Do you have access to it? Okay, let's get rid of those. Do you have intent? Well, no, I just think it'd be better if I didn't wake up. But do you intend on doing it? Nah, I'd never do it. Well, why? Well, I could never do that because of my religion. Well, I'd never do that because of my grandkids. Or for some folks, I could never do that because I have a dog that relies on me. Look for those anchors, look for those resiliency factors. And then a follow-up plan. Okay, what are we doing on Monday? What are we doing on Thursday? Again, like breaking it down. Sometimes crisis intervention can be really moment by moment. What are you doing in the next hour? What are you going to do for dinner? What are you going to do for, okay, so-and-so's coming over, and then when is that person leaving? So really, really some basic cognitive kind of breaking. Okay, that was fun. Getting kind of heavy. So let's take a rest. Let's take a little detour. I have 5 minutes left. Data point number 2. But before we do data point number 2, I want you all to kind of do this boxed breathing approach. So see that square? I don't have a laser. Nope. Sorry, I might have almost lasered you in the eye. If you can just breathe in for that breath across the square. Breathe out, down the square. In. Out. So we're tracing a square. In. Out. Big breath in. Big breath out. Do it one more time on your own. Whatever feels like the right timing, the right breath. Okay, let's do it one more time, just because I've had too much coffee and I can tell my body needs it. Okay, now I want you to write your second data point. The first data point was how stressed were you this morning when we first started our talk. Jot down your data point number 2. Scale of 1 to 10. 1, we're on the beach. 10, we're in the ER. What is your data point? Is it any lower than what it was when we started the talk? Is it lower than maybe when we started? These are the little mini cognitive breaks that we do for patients and for staff. I learned this trick from a psychologist I worked with, and we were in the hospital, and we had to do a visit, and it was going to be really stressful. And we're like shuffling down the hall, and she's like, in breath for 1, out breath for 2. In breath for 3. I didn't know she was doing this, and she's like way behind me. I'm like, what are you doing? We gotta go. She went into that room at a 4 when I was like at a 7, right? So for busy nurses, you're in the clinic, I get it, whether you're inpatient, outpatient, whatever field, wherever you are, even switching from work into mom mode or family mode. What is that tool? What is that break that you need? Giving yourself that space. Okay, I got 2 minutes left, so I gotta hurry. Okay. Really, really quickly, clinical interventions. I just thought it'd be fun to kind of go over what are the therapies that are really effective with patients and families. Narrative therapy. That's what I started with, my story. My grandma was this. She was a nurse. She was awesome. My grandfather was this. Patients want to tell their stories. There's a lot of power in it. I just need to be heard. I went through this, and then this happened, and then you're not fixing it. You're just going, yeah, it sounds really tough, right? That's honestly at the secret sauce of what social work is at its core, or therapy. It's just listening. And it's not telling them what they should think. Motivational interviewing, I think of Chris Farley and that motivational speaker. Anyone with me? But it's Socratic questioning. It's that kind of mirror thing. Hey, what does that mean to you? Like quality of life. Well, I know what that means for me, but you tell me, what is your quality of life? So helping them start to identify what the question and the answer is for them, because usually they find it. Traumatic responses and recovery. I got a master's through DU, and I got a certification in trauma responses. And because that's, again, when the mushroom cloud goes off and people know they have cancer or COVID happens or the worst happens, we respond differently. So traumatic lenses of how we view things is really helpful. Mindfulness-based stress reduction techniques, grounding strategies, the breathing, box breathing we just did. That's another example. And really, it's empathy and validation. One of my favorite examples is like this iceberg here. 10% is what we see at the top. I'm losing my hair because of chemo. 90% is the emotion below it. Well, you could just get a wig, and you could just fix it, right? We want to fix it. We see a problem, we fix it. What does that person really need? Well, It's okay to be sad. It's a grief. It's a loss. It's who you are as a person. It's how you identify yourself. It's you at your core. It's those core beliefs, right? So you don't have to fix it. You just have to kind of sit with them in it. And this is what, therapists do. We love sitting in this kind of space and working back up, because then patients usually find their way kind of with the solution that works for them. And acknowledgement, you can acknowledge something, but you don't have to agree with it, right? I see that that's heavy. I mean, I'm not sure that makes sense, that symptom or whatever, but hey, yeah, I get it. It's worrying you. Emotional regulation, that's just pumping the brakes, that stress scale. Instead of oscillating from a 3 to a 9, you got to pump the brakes and, make sure that you can just that check-in, like I was doing that with that example of walking down the hallway with my dog. Cognitive diffusion is how we separate our thoughts. We are taught how to think. There was another slide here I'm going to cruise through. We go to school, we know how to learn, but are you taught how to think about how you think, right? So we have to get people to stop and think, like, what is that thought doing? Like, oh, I'm never going to be good enough. Like, what does that do to a person's psyche? So a lot of this is cognitive behavioral therapy, which is the gold standard. But I'm going to just try to keep us on time and skip a bunch of these slides that are really kind of how to get patients going. Gratitude at bedtime has actually been studied through the University of Berkeley, that if you write down 3 things that you can have gratitude for at bedtime, it can retrain the neural pathways in your brain the same way that an antidepressant does. So for patients that don't want to take a medication, yeah, I'm depressed, but I don't want to take another antidepressant. Gratitude, bedtime. I'm grateful I didn't flip that person off when they cut me off, right? It can be a small thing. People can be complacent, like, oh, I'm grateful for my kids, and I'm grateful for my dog, It's like, hey, I'm grateful that I, took that time for myself, or I did something hard, or today was a tough day, but I made it through it. This is a practice. It's those neurons that fire together, wire together. That's what the science shows, is that if they do it over and over and over again. So when I said, I'm not a runner, guess what I've learned to believe? I'm not a runner. So what do I tell myself? I'm not a runner. I'm really working hard to not that hard, but but I'm too sensitive. That's not a bad thing. That's why I do what I do, because I can sit in this hard stuff with patients and I can get it. But it's learning how we kind of go back to those old schemas and those old views of how we view ourselves. The best intervention I found in oncology is something called acceptance and commitment therapy, which is a version of cognitive behavioral therapy, but it's acknowledging that this is tough and this is hard, but we're going to do it anyways. It's that you can still kind of override that. And there's a wellness wheel that I do with patients to kind of give them direction. What is it that you value? What are you hoping for? And this is kind of speaking to that fight mentality in cancer that we're all familiar with. Has anybody heard this Stuart Scott quote? It's really, really helpful for patients, especially those that are metastatic or advanced or, palliative in treatment. And Stuart Scott, in his book, he said, when you die, it doesn't mean that you lose to cancer. You beat cancer by how you live, why you live, and the manner in which you live. And that's acceptance and commitment therapy at its core. It's, why do you keep going? Why do you keep, showing up? Well, it's because I want to be there for my family. The man in the arena, it's how to dare greatly, and that's a beautiful quote too that I don't think we have time for. But in the end, I just want to thank you for your time today. Hope you felt safe talking about this topic with me. I hope it was helpful, and I hope you feel empowered in the work that you do. So, thank you.